Good morning, everyone. If you would please go ahead and take your seats so we could get started. Okay. Thank you. Happy Red Friday and welcome to our first annual Health Summit. A few things I'd like to get started this morning. First of all, we're excited to welcome you to our first summit that we hope to be an annual event. We have a registered attendance of 187 people. So I think that's really exciting for our first summit. So I have a few people I'd like to recognize this morning. So if you are in this group that's being called, please stand and stay standing, and then please hold your applause till the end. So we'll start with our Kansas senators and representatives. If you're in the room, please stand. Thank you. Go in the back. Okay, Johnson County mayors and other city officials. And we have them registered. Johnson County leadership and Board of County Commissioners. Region 7 Health and Human Services staff. They must be running late. And I believe we have a representative, hopefully she's made it in already, from Sharice David's office. Janelle, if you're here. Okay. And so let me get into the people I know are here. So, and if you're in this group, please stand. First of all, I'd like to thank, I'm sorry, I didn't even introduce myself. I'm Eldana Chestnut. I work for Johnson County Department of Health and Environment. I am the Division Director of Child Care Licensing and the Bridge Chair and on Public Health Leadership Council. So if you are on the conference committee, please stand. I really appreciate all their hard work and their help. The next group would be Ashley Follett, helping with all the creation of the program. I haven't seen Ashley this morning. Deborah Uribe, I know you're here. And Brett Williamson. I know she's in the building, so there she is. They help us put together all the registration and the reporting and the monitoring of the registration, and couldn't done it without them. The next group would be our Johnson County computer people, technology. My brain is just a little wound up this morning, but they have been phenomenal. I couldn't have done it without them. And also Jason with JCCC, and we couldn't have done it without all of their work. So thanks to all their hard work, we are able to record this event, and it will be available for viewing at a later time. And we also are working on a live streaming option so that folks can watch that. And again, they've done so much hard work. I really appreciate everything they've done. My last group to thank this morning would be all of our volunteers. So if you're one of the volunteers that's doing a breakout session, a flip chart, facilitating, note taking, lunch, or registration table, please stand. All right, again, you can't have a conference without a whole team, and I really appreciate all of them and all their help. So next thing I'd like to get into, you'll notice that there's flip charts throughout the rooms that have questions written on them. So these are part of our feedback session that we'll be working on more this afternoon. But when you have time, please do go around to those. There's 4 breakouts, and we only have time for you to attend 1. So if it's a session that you're not going to be attending, please do take time to come up to the other flip charts and post your information on there. There's sticky notes at your table, and your feedback is very important. We really wish we had time for you to attend all 4, but it just doesn't allow. Your feedback is extremely important. It will be used for helping the health department move forward along with our PHLC, which is Public Health Leadership Council, and you'll hear more about from Sami. But we really need your feedback, and we appreciate our partners. And again, that will be available to you at the breaks and if you finish lunch early and if you get back from the breakouts early. So do take time to provide your comments. A few housekeeping things to cover. The restrooms are located. There's one set that's right out this door and take a left. It's at the end of the hallway. The other set of restrooms are out this door, just to the hallway, just to the right of the elevator, and they're on your right. In case of severe weather, there will be an announcement made, and there are set rooms that we would go to if we would need to shelter in place. If there is a fire, please proceed out this is the closest door. Please proceed out these doors and out into this area over here, where there's a parking garage, and that's the meeting place, and everybody would need to assemble over there away from the building so our fire departments can get in and do their work. If there is an emergency or of other type that you need to access campus police, you can go to any campus phone and dial 4111, or you can dial 469-2500, or you can reach myself or any of my conference committee, and I know how to access them. So with that, I just want to welcome you again to our conference. Happy Friday, Red Friday, go Chiefs. And now my great pleasure to introduce Dr. Samuel Ariola. Dr. Ariola is the Director, Department of Health and Environment, Johnson County, Kansas. He is leading the collaborative efforts to modernize public health infrastructure and approach in Johnson County. He also leads current efforts to mitigate the impacts of COVID-19 on our residents. Previously, he served as the Interim Director of Health and the Deputy Director for the Metro Public Health Department, Nashville, Tennessee. He is public health generalist, a toxicologist, and has been strongly involved in the aspects of health and all policies, health equity, social determinants of health, public health risk assessment, air toxic assessments, vehicle emissions, air pollution, indoor air quality, pest management, insecticide, and for mosquito control and community water fluoridation. He is passionate about community engagement and public health risk and interventions, and understanding that they are critical to ensuring assumptions reflect that it's happening in the community. He was the Director of Bureau of Environmental Public Health and past President of the African Society for Toxicological Sciences, which organizes scientific conferences on environmental public health and toxicological issues impacting the African continent. He has partnered with international agencies to address global health issues and spearheaded the formation of Toxicologists of African Origin Special Interest Group as part of the Society of Toxicology. He taught environmental health and industrial hygiene classes for the Master of Science in Public Health at Meharry Medical College for several years, reviewed for major public health journals, and has been featured in several media addresses for public health issues in the community. And lastly, he has served as an expert witness in several public health related issues in courts. With that, I give you Dr. Ariola.
Good morning and welcome to the inaugural annual health summit for Johnson County. We are excited to have you, and both here today, but also as partners moving forward. Today, we would go over some of the where we currently are in terms of health. We'll talk through how we want to be sure that Johnson County build the right infrastructure that will support the health of our residents, both now and in the future. And we want to do that, give that opportunity to every resident. We want everyone, all, to have that opportunity. We'll talk about how we want to nurture environments and conditions that support health throughout the country, both now and in the future. So in terms of health, thank you very much. Okay. Right now, we are doing pretty well when we look at health in the county. The Robert Wood Johnson County Health Rankings, we have been number 1 out of 105 counties for several years. And in other rankings of counties across the United States, we have done very well too. Now, why have we really done well? We have taken some steps that have been supportive of the efforts to make us a healthy county. We have very, very good public and private agencies. We have really involved, well-organized community groups. Our socioeconomic status is pretty high, and that means a lot. It means things like we have high level of education, high level percentage of our residents are insured. And we have parks and library. We have good, we were about ensuring that we build good schools and we have good parks and have library, and we put resources into those things intentionally. It's what drive people here. And as you will see as I talk about health, how health is broad, and all of those decisions, while not initially thought of as contributing to the health of our residents, they really do, because health is broader than just coming to the health department to take your flu shot. Yeah. So this. Yeah. So that's now moving. Yeah. After well, I will keep talking while we wait. So in the next slide is really talking about taking these numbers in perspective. It is understanding that we are number 1 out of 105 counties in Kansas, a state that's number 34, 35 out of 50 states, in a country that's 28 out of 34 OECD countries. So you've got to take that in perspective. And so the point there is there's a lot of opportunities to be better. And Elizabeth, our director of epidemiology, Charlie Hunt, our deputy director, will get into a lot more of this data. Here's an example for, this is infant mortality. That's the number of deaths per 1,000 births. Now, the number for our county is the 3rd row, which is about 3.9. That's good. That is better than the average of the state. That's better than the average of the county. But when you break that down and you look at it further, if you are white, there will be 3 babies that die out of 1,000. If you are Hispanic, that number jumps to almost 4. If you're Black, that number is over 10. So while the number looks good overall, when you look at it, you know there's work to be done. Again, Elizabeth would and Charlie will get into this. Also in our county, I talk to people a lot. We are pretty rich. The socioeconomic status is good, but we have a lot of people that live in poverty. And these are numbers from 2018, 2019. That number is higher than it was now. About 33,000 of our residents live in poverty. So if you look at that as a city, it will be the 6th largest city in our county. And just to talk about poverty, has a direct link to health. If you're poor, more often than not, your health is poor. Same thing, we talk about life expectancy. Again, Elizabeth will get into that a little bit more. Within the county, our life expectancy was 81 years, good, higher than the national average. However, when you look, depending on where you live, if you live in that junction of Sunny Mission Parkway and Quivira Road, you can expect when you are born to live 12 fewer years than if you were born 5 miles away from that place. There's a saying in public health that your zip code may be more important than your genetic code. When we talk about creating conditions and environment that support health, and when we talk about making those conditions the easier option or the default option, that's what health is. That's what we're trying to do, to create those conditions where everyone, no matter their age, no matter their sexual orientation, no matter their age, and no matter their race, have the opportunity to be as healthy as they can. We're doing pretty well, but as you will see in several of those data, where you really look deep, that opportunity can be available to everyone. We can work harder to make that opportunity available to everyone. So again, look at our county. We're growing very fast. Our demographics are changing. If you look at the graph there, by 2036, we will have over 720,000 residents here. By 2066, it will be over 900,000 residents. Also look at what's going on with the demographics. By 2066, about 50% of the population will be minorities. That's the reality. That's the reality of the county. And so actually in a few years, right now we account for about 21% of the total population of Kansas. It is projected that over 30% of the population will live in Johnson County in a few years, of the Kansas population. So we've got to be ready, not just to assure health now, but be ready to ensure that we put things in place that will allow us to ensure that everyone can be as healthy as possible. Of course, as you've seen in the data, health equity is still a goal for us. We're not quite there yet. And as you saw with COVID, there are changes in public health risks that we have to put in place resources to ensure that we can respond to those appropriately and build even better resilience moving forward. Okay, so keep this question to this when I ask, we're healthier in 10 years because, and I've posed that question to the Leadership Council and others, and I'll come back to that, okay? So this is, let's talk about the United States. We spend a lot of money on healthcare, and health happens outside of medical care, yeah? Public health is everything that you do before you need to go and seek clinical care. It is the opportunity to work. It is having access to adequate and appropriate housing. It is how we police. It is how we build our cities. All of those are involved in determining whether we become a healthier county. And so if you look at this, we are spending about $12,000 per capita in the United States. And the rest of the OECD countries are spending about $5,500, less than half. But also look at just one indicator here in terms of life expectancy. They're doing a lot better than we are doing by far, even before the recent drops that we are seeing. But if you look at those countries, they are investing in those upstream factors outside of clinical care. So our clinical care are good, and we're glad that they are. We have access to those things. But to become a healthier county, a healthier country, we've got to do a little bit more than that. Health happens in public health. It's a lot of public health is everything that you do before you need to go for clinical care. It is getting your vaccines, and don't listen to all those things about COVID vaccine and those things. Vaccines are the reason why we have a huge improvement in the quality and quantity of life for the past 100 years. They are responsible for eradication of several of those illnesses that we had to deal with in the last century. So vaccines are very critical to our efforts to protect our residents, okay? And so what I'm getting into some of the things. By the way, High Five was a CDC program. High Five really means health impact in 5 years. Just looking at those things are, again, emphasizing why we have to do more than the advancement in health, in clinical care, medical care that we have made, is to look at in this pyramid, at the bottom of the pyramid, we talk about social determinants of health, but let's just not get into those technical terms. These are the things, upstream factors. The things, look, when we walk downstream, which is what we currently do, you can imagine that as we are really managing and minimizing damage. That's what we do. We have high cases of TB, high cases of cancer, or whatever. We pull resources together to deal with it. Those are not as impactful. In this chart, and Elizabeth will get into that more, up there, you look at clinical intervention. We know that that contributes only about 10% of the modifiable factors that impact health. But look at the bottom of this pyramid, look at those social determinants of health: adequate housing, mass transit, attention to climate, making sure that people have access to sidewalks, making sure that we don't have food deserts in the county. All of those things are things that impact health bigger. I call those the influencing the outcome rather than doing damage control downstream. That's what we are trying to get to as a county. Also, the next one, changing the context. Charlie will be leading the breakout session today that we're calling Culture of Health. That's what that is. When you build, when you have sidewalks available to everybody, when you build, when your built environment takes into consideration your older population, 65 plus, you are building for everyone. This week, I spoke with a group, Community for All. That's public health. That's changing the context. When we tell people to go and walk or eat better, I can only pick from the options that are available to me. If you want me to go out and walk, make sure that when I get out, I don't have dogs running at me. Make sure that the sidewalks allow me to do that. Make sure that when I'm out there, I'm not scared of policing there because of I'm wearing a hoodie or what I look like. So that's changing the context. It's building a culture of health. It's making sure that the environment supports health. And so those two bottom are really what we're trying to focus on as a county, working with all of you. It's the same thing. That ellipse that you see towards the left are upstream factors. When we focus on those, we are focusing on and determining in some way the outcome. When we focus downstream, which is what we tend to do, we're basically doing damage control. But you also see two things. At the bottom of this place, you will see collaboration. You see community engagement. You will see policy. Another session we have today, Tatiana is leading that. It's health in all policies. It's really hardly any policy you make that will not have an impact on health. And that's part of when you make decisions about capital improvement projects, where you make decisions about where you want to repair sidewalks or locate parks and library. It has impacts on health. As well as we have built these resources in the county, they're not available for everyone at the same level. And those are the changes that we need to make to be a healthier county. And so again, back to that question, we will become a healthier county when we intentionally focus on health, like we did schools. We wanted to build the best schools. We will become a healthier county where we intentionally focus on health as we did parks. We will become a healthier county when we intentionally want to be as we did with libraries. That's what it takes when we create environment, when we nurture and foster environments that is for everyone and it's everywhere. No matter, I was talking to, I think it's one of our leadership council in Nauru. Part of our data challenges, for example, is data for the LGBTQ community, for example. There are some estimates that about 10% of people in this region are part of that family. We don't have data. We don't have things that we do to know what's going on with them. So those are the the things that we have to, and I know people, there was a question recently about what epidemiologists do. I'm happy to sit down with you if you don't know what it does. It is a core discipline of public health. It is how we use data to inform our decisions. It's how we use data to understand what's going on. The charts that I've shown you were produced by epidemiologists, and you see even more charts moving forward. We become a healthier county when we create healthy conditions everywhere, in all places, and create that opportunity for everyone, no matter what their political leanings are. That's how to become a healthier county. And so again, just health is broad. We must intentionally define it as such. When Tim Dewis is going around, I love what Tim does every time, he's promoting mental health. Here's how we define health. Health is not just the absence of infirmities or diseases. It is a state of complete physical, mental, social well-being. So all of the things that's why we say that mental health is public health. Public health is mental health. That's very important. If you look at our leadership council, which I'll talk about soon, you will see that we have a lot of people that are focused on the built environment. When you make decisions about zoning, when you approve projects, they have impact on health. And so we have to understand those and we have to focus on upstream factors, and we have to make sure that we build collaborative structure that supports health. So this is, health again is more than you coming to the health department to get the flu shot. We can't do health by ourselves. That's why we talk about the local public health system. That's why authentically engaging the community, building trusting relationship, not waiting for a pandemic to reach out to our Latino or African American populations. We have to have those trusting relationships built. That's critical to supporting health. And so that's an example. In our leadership council, we've pulled all of this together. And so today we are unveiling a document, and this is Moving Health Forward document. I think we have this passed around on the table. If you scan this, you'll get a copy of it. In that document, you will see, again, this document is a key step for us in moving health forward, and for you, for all of us to work together. You will see where we are as a county. It's a 30-page document, so we couldn't put everything in there. You will see where we're trying to get to, how we plan to get there, and who. It's everyone. It's a collective responsibility. So make sure you scan one of these. I think we have a few printed, about 10 copies that I don't know how we distribute that, but scan that. And I've spoken to a few people in academia and other places. I've been all over the county talking to people the past few months. We actually have been, Charlie and I have traveled a couple of times outside, just wanting to make sure that we're working with all of our partners and not-for-profit organizations. For-profit organizations, our cities, to ensure that we are working intentionally to promote health. Yeah. So again, think about that Public Health Leadership Council. We have brought together a team, and several of you are here representing different organizations to work with us, to understand the community. Here's the deal. The assumptions that I make about the community, sitting by myself, is unlikely to appropriately reflect the community. Those days when experts sit at the table and in their offices and figure out the problem of a community and what the solutions are and take it to the community, those days are over. For the things, the interventions that we have to work, the assumptions have to represent the truth. They have to reflect what truly is going on. If they don't, then it's fundamentally wrong. The risk assessment is wrong, and the risk management will be wrong. For those assumptions to truly reflect the community requires that we work with the community. So in here, we've got people that represent healthcare organizations. We've got our first responders, police, fire. We have UCS. We have our health partnership. We have community members. We have different groups that are collaborating and working with us to let us understand the community, but also they represent key organizations to take what we are trying to do also into the community. And the 4 pillars that we are working on, that we're asking all of you to work on, is also the 4 breakout sessions that we have. And these are very critical to health. I've talked about health equity. It's absolutely impossible to do public health without addressing health equity. That's what public health is. Public health looks at gaps, looks at populations that have been impacted, and we look for opportunities to address that. Not to bring the high performance down, but to lift the people at the low end up. That's what health equity is. You can't do public health without doing that. I've talked about health in all policies. I've talked about building a culture of health, and I've talked about building bridges into the community. We are working to enhance those relationships that we already have, but we want to build new bridges into where we need to. We want people that are not typically at the table to have the opportunity to be at the table. We're working on making that happen. And so we are going to be working with all of you to do that. Now, I just want to recognize, these are, if you are here and you are part of the Public Health Leadership Council, if you would just stand up for a minute. I want to just show their names, but also to show the different organizations that they represent. Doesn't mean that that's all that we need. It just means that it took us a long time to narrow that down, but all of you are needed. All of you are represented. If you're part of the Leadership Council, will you? Yeah. Yes. And we have already had 3 meetings. We have another one coming up. And the first task that we are tackling is partnership. It is building authentic relationship with the community and trusting relationship with the community. Thank you for listening to me. And I'm going to go, our next presentations will be by Charlie Hunt, Deputy Director, and Elizabeth Holshoe, Director of Epidemiology. Charlie is the Deputy Director for the Johnson County Department of Health and Environment. Prior to his current role, Mr. Hunt was a senior analyst with the Kansas Health Institute, based in Topeka, Kansas, and Deputy Director of the Center for Sharing Public Health Services, a national initiative that's funded by the Robert Wood Johnson Foundation and managed by the Kansas Health Institute. Mr. Hunt previously served as state epidemiologist. Again, he will be very happy to explain what epidemiologists do. And was also the Director, Bureau of Epidemiology and Public Health Informatics with the Kansas Department of Health and Environment. Mr. Hunt earned a master's degree in public health from the University of Kansas, and really wants you to know that he graduated from the University of Kansas. Elizabeth, our Director of Epidemiology, who you all saw a lot during the COVID response, has worked with the Department of Health and Environment since 2015. In her role, she oversees a team of population health epidemiologists whose goal is to utilize data to drive policy change, allowing all Johnson County residents, again, all Johnson County residents, to live their healthiest lives. In addition to our role at the Johnson County Department of Health and Environment, Elizabeth also facilitates workshops throughout the county for the FBI and CDC, teaching local law enforcement and public health how to conduct joint investigations in the event of bioterrorism and other suspicious outbreaks. And this is really good. In 2021, Elizabeth was named by the Beaumont Foundation, one of the top public health not-for-profit organizations, as one of the top 40 public health leaders under 40. Prior to our current, yes. Prior to our current role, she served as a population health epidemiologist with DHE and an infectious disease epidemiologist at the Kansas Department of Health and Environment. She obtained a master's degree with a concentration in public health, microbiology, and emerging infectious disease from the George Washington University. Join me in welcoming Charlie Hunt and Elizabeth Horshaw. Thank you.
Thank you very much, and good morning. It's wonderful to be here with you this morning. One thing that was not included in the introduction, of course, is that it's good for me to be home. I started my career at Johnson County Department of Health and Environment many years ago. I'm not going to tell you how many years ago it was, but it was a long time ago. But it's really good to be back. It was a wonderful experience then, and so it's a pleasure to be back. So I'm going to be kind of reinforcing some of the things that Sami talked about and trying to set the stage a little bit about how we think about health. And then I'm going to turn things over to Elizabeth to talk about the story of Johnson County with respect. But I want to talk a little bit about my understanding of the comprehensive nature of health. Now, Sami presented to you kind of a definition of health, and that definition of health encompassing physical, mental, social well-being comes from the World Health Organization, and it's not a new notion. This is a definition that was developed back in the 1940s. And those, through school, we learned that definition. We understood that health is broad. But for me, my understanding of it actually started when I was here at Johnson County many, many years ago. I started my career as a communicable disease investigator with the health department. And so it was my job. You all know what case investigators do now. And it was my job to investigate reportable diseases. And so we would get, back in those days, they came in on little green postcards, and we would call people and ask them questions about their exposures and who might be at risk. And we were dealing with, at the time, hepatitis A outbreak in the Kansas City metro area. This was before there was a vaccine available for hepatitis A, and the only way to prevent it after exposure was to have immune globulin. And so we were trying to figure out what was going on and how we could get a handle on this. And it happened to be common among people who are using drugs. That seemed to be a common risk factor. And I called one of the patients that was diagnosed, and it was a young mother, and she had a daughter. And I can remember that this child was screaming and crying in the background. And I felt that at the time that the mother was really struggling. And even during the interview, I felt like she was probably under the influence of drugs. And it was very difficult for me, and it really made an impression on me. And she began yelling and screaming and swearing at this young child in the background. And I felt helpless. I wasn't sure what I could do. Now, I was able to make the arrangements for this young mother to bring her child in to get the IG shot, and she would have been fine as far as hepatitis A is concerned. But it was all those other things. What kind of environment was this child growing up in? What risks was she facing? And there was nothing that I could do about that. So I made the difficult decision as a young communicable disease investigator to do the only thing I knew how to do, and that was to call Child Protective Services and explain my concerns. But it really is, as my career has gone on, it really has helped me understand that health is much broader than just taking care of the kind of the immediate needs, the acute needs. It really is about the circumstances that we all grow up in and live in and so forth. And again, all these years ago, it still has made an impression on me. So that's it's helped to kind of formulate the way I think about things, the way I go about my work as an epidemiologist, and now in my current role. So as epidemiologists, things we do is count, and so I want to talk a little bit about one of the things that we count, of course, is mortality. And so it might be a little bit hard to tell from the graph here, but I have a chart here with two lines on it. The line that is going down over time is overall mortality in the United States. The line that's going up is life expectancy at birth. And I won't go into the specific numbers here, but suffice to say that the trends are very obvious. Over time, mortality in the United States has gone down dramatically, and life expectancy has gone up dramatically. And in fact, there have been about 30 years gained in life expectancy over the last 120 25 of those years can be attributed to public health measures. Now, healthcare is certainly important, and I don't want to diminish the importance of that, but it's really public health measures that have contributed to the largest gains in life expectancy. So it's things like clean water and sanitation. It's preventive health services, such as immunizations. It's occupational injury prevention through workplace safety measures, and many other things that we could talk about. But it's really those population-based measures. As Sami said, public health is about what happens before you need to go to the hospital. Now, the one thing that I'll point out on this graph is you can see the little blips back just before 1920. We saw an increase in mortality and a decrease in life expectancy. That, of course, was the influenza pandemic that time, and we see a similar pattern with COVID now. And so these large events certainly have a substantial impact. But now what I'd like to do is despite these trends, I'd like to focus on what's happened over just the last 20 years. So, and just a disclaimer, as an epidemiologist, I want to make sure I point out that I've changed the scale of this graph here to really emphasize the difference. So in 2015, we saw something that hadn't been seen for many, many years, and that's a decrease in life expectancy in this country. And it happened again the next year. And that is a trend that hadn't been seen since World War I. So in a nation with all the resources that we have, why was it we're seeing a decrease in life expectancy? It's not something that we were accustomed to experiencing. And Sami alluded to this. It's not because we're not spending enough money on healthcare. In fact, the United States spends far more on healthcare than all the other developed nations in the world. It's not because we're not spending enough on healthcare. But what are we getting for that? This is a graph that shows a relationship between life expectancy at birth and expenditures on healthcare. And you can see the little orange arrow there, that's the United States. Way out to the right in terms of on healthcare expenditures. But many other countries are doing much better in terms of life expectancy at birth. So there's something going on here. It's not spending on healthcare. When we look at life expectancy within the US, we also see that it's not equally distributed. In fact, there's a difference or a gap of 20 to 25 years based on where you live in this country, with low life expectancy at birth being concentrated in certain geographic areas. Sami mentioned even the differences within our county, where we see a big difference in life expectancy just a few miles apart. So it is important. Circumstances are really important here. So what is it that makes us healthy or not? What is it that's driving differences in life expectancy, these differences in mortality and morbidity patterns? Well, I'm going to take you back a little bit to think about kind of a traditional model of what causes death. And that is that the basic premise is that we're born, most people born generally healthy, go on through life, we develop disease or an injury, and die. And we have a way of counting that. When I was with Kansas Department of Health and Environment, one of the areas that I oversaw was the Office of Vital Statistics. And so this is one thing we did. We counted how people died, and we typically did it by looking at the cause of death that's listed on the death certificate. And as you probably very well aware, chronic diseases dominate the leading causes of death. It's things like heart disease, cancer, diabetes, lung disease, and so forth. And so that's one way of thinking about what's causing death. But what is it that are causing those chronic diseases? Well, it turns out that a few risk factors contribute to most of those leading causes of death. It's tobacco use, it's physical inactivity, and it's diet. Those three risk factors account for a very large percentage of deaths. And so this led to kind of a change. This is called the actual causes of death. And there were some seminal papers that were published in the early 2000s that really talked about what the actual cause of death were. And so that led to a different model that health is really determined by lifestyle. And if we can just impact the health behaviors, if we can get people to not smoke or use tobacco, if we can get people to exercise, if we can get people to have a good diet, then we can reduce the risk, particularly of chronic disease, and people will live longer and healthier lives. And so this is kind of the public health 2.0, with public health 1.0 being focused on infectious disease prevention. And it turns out that about 60% of premature morbidity can be attributed to those factors, those lifestyle factors, and what's going on in the environment. So again, all we have to do is get people to practice healthy behaviors. It's as simple as that, right? Real easy. But if you live in a community that is dominated by fast food restaurants and convenience stores, and you don't have access to healthy food, fresh fruits and vegetables, then it becomes not so easy. That individual choice becomes much more difficult. If you are surrounded by your peers who smoke, who use smokeless tobacco products, who vape now, that puts pressure on you and makes it much more difficult for you to make the healthy choice. If you live in a community where have sidewalks, you don't have safe street lights, you don't have a park that has good playground equipment, and you're afraid to send your child out to play in that park, it's not safe for them to get across the street, then they're going to probably spend more time sitting on the couch playing video games. So it makes it so that maybe that choice is not as easy as we might think. So that's really what we're trying to impact, is trying to make our culture, our environments healthier, and make it easier for people to make those healthy choices. And so again, it's 60%. It's not just about the lifestyle, but it's also the circumstances that we find ourselves in that really contribute to health or not. And you'll see this term, I'm sure many of you are familiar with the social determinants of health, or the upstream factors of health. It's things like education, it's access to healthcare, certainly, it's good jobs in the economy, and so forth. And so we'll be talking a lot about this throughout the morning and throughout the breakout sessions later this afternoon. So again, this led to a different model of disease and death, and that is the social determinants model. So that really it's those factors, the environment, the circumstances that we find us in addition to making good choices about health behaviors, but we have to make it easy for people to make that decision. And now you could also draw a line between those social circumstances and directly to disease and death, because we know that the impact of chronic stress can lead directly to poor health outcomes. There was a phenomenon that occurred, again, kind of looking at what happened with respect to life expectancy in the last 4 years. There was a couple of economists from Princeton, Angus and Deaton, that really dove into looking at the causes of death and what was going on. And what they found is that in addition to these chronic diseases, that there were increases in mortality, particularly among middle-aged white adults, that were really driving a lot of the declines in life expectancy. And again, this is a phenomenon that was unique to the U.S. You can see that the line there with the U.S. going up, but while generally speaking, the other countries were trending downward. And really, it was attributable to just certain causes, and this led to understanding of deaths of despair. And they saw that the increase was largely driven by increases in drug overdose, suicide, and heavy alcohol use, the so-called deaths of despair. And again, that was based on the U.S. We were interested in looking at this in Kansas. And so when I was at Kansas Health Institute, Dr. Steve Wolf from Virginia Commonwealth University came in and looked at mortality patterns here in Kansas. And there's a report published on Kansas Health Institute website that really speaks to this, that looked at, again, what were driving the mortality patterns in Kansas. And again, we found the same patterns in Kansas that were being seen across the U.S., and that is a substantial increase between with respect to drug overdose, suicide, and alcohol abuse. In fact, during a 20-year period, we saw drug overdose deaths increased by 585%. We saw alcohol deaths go up by 440%, and we saw suicides go up by over 50%. So again, Kansas was not immune to this phenomenon. I'm going to wrap up by just saying that we also looked at this data by region, and Johnson County was in the type right-hand corner there. We also saw increases in these stress-related condition mortality in Johnson County. So that can again helps you understand that the phenomena that we're seeing Johnson County has not been immune to that. And with that, I'm going to turn things over to Elizabeth to finish the story of Johnson County.
Thanks, Charlie. Morning, y'all. It is great to be back in a room with people. And for the first time probably ever in my career, I don't feel like I have to stand up here and explain that as an epidemiologist, I am not a skin doctor. So that's sort of a nice relief for me. But I do feel like since March of 2020, when the New York Times declared epidemiologists as rock stars, which clearly we've been a little marred since then, I do feel like we do need to talk about what it is that we do as epidemiologists, because it's not just COVID, it's not just monkeypox, it's not just communicable diseases. The reality is, as you saw Charlie talk through this change from where we started with infectious disease to chronic disease to social determinants of health, epidemiologists have been critical in driving these conversations and counting in assessing the health of the community and the country. And that's really what epidemiologists do, is we use data to drive programs and policies. And my team in particular at the health department, which we are very thankful to have because our BOCC voted for it in the middle of the pandemic, our goal is to look at these things. We are a team of population health epidemiologists who work on things like housing and corrections and mental health, maternal child health and environment. So I just want to sort of level set about that is what we do as a team, because our hope is that as we move forward to make this community healthier, we'll be working with all of you in various capacities with your work to drive forward your initiatives to improve the health of our community. So as Dr. Arriola said, I'm going to talk a little bit about Johnson County. So if you were to ask somebody in any other part of the state, Topeka, Colby, Kansas, Wichita, or the Metro, who would they say lives here? What are some words that they would use to describe Johnson County residents? Wealthy, what else? White, anything else? Well-educated. That's the picture, right? I'll say that I'm not from here. The first time I stepped foot in the state of Kansas was for my job interview with Charlie Hunt 12 years ago. And the second time was when I moved here. So I didn't really know a lot about Johnson County when I moved from KDHE to Johnson County Department of Health and Environment. And I'll be really honest, this was the picture that I had in my head, because I think it's what everybody believes. But you've already heard from Dr. Arriola that our population is changing. Most of you in this room know that. You see it. And the reality is that because historically our population has looked like this, it really has afforded us a lot of things. Dr. Arriola spoke about this, right? We're the healthiest county. We've got the best schools. We've got the best libraries. We've got the best parks. We have a fantastic community to live in. The reality is that makes us very attractive. But it's because of this wealth and this whiteness and this education that has allowed us to have this. And part of what we look at, of course, as Dr. Arriola stated, was life expectancy. And Johnson County looks really good on the surface, right? We are well above the state, the US, most other communities throughout the country. But when you start digging in a little bit deeper, things aren't quite what they seem. We have a year life expectancy difference between two neighborhoods in our community just 5 miles apart. But I want you to think about what that means for your retirement. What do you hope to gain in those 12 years between ages of 74 and 86? More times with your grandkids, more time to travel, more time to give back to our community and volunteer. Those are things that we're missing when we lose our residents earlier because of these systemic issues that we see in our community. So let's take a look specifically at these two communities to try and understand what it is that makes them different. So only 5 miles apart. We're going to first talk about housing burden. So we in this community have talked a lot about housing, which is excellent. We've driven the conversation. People understand that housing affordability is a problem here. And one of the things we look at is housing burden. So what percent of the population spend more than 30% of their income on housing? This is a really critical measure because it means if you're spending that much money, you don't have a whole lot left over. So if you look at community A, they're spending 33% of their residents are housing cost burden, whereas in community B, only 17%. Poverty, mind-blowing. We talk about children, right? When we talk about life expectancy, it's the amount of time somebody who is born in that neighborhood is expected to live. In community A, 1 in 5 kids live below the poverty level. In community B, 0%. Median household income, almost double in community B. The race and ethnic breakdown is very different. About 1 in 5 of the residents in community A are people, again, practically 0% community B. And then we see the life expectancy. Now, the reality is this is not the only disparity we see when we think about race and ethnicity in our community. Now, the numbers really aren't all that important, so I don't want you to see like what exactly is that rate. But what I want you to pay attention to is the pattern. This is overall mortality. Our Black non-Hispanic, NH non-Hispanic, our Black non-Hispanic residents are dying at a higher rate than any of the other races in our community. We see the same pattern for cancer. We see the same pattern for heart disease. We see the same pattern for hospitalizations, for stroke, diabetes. The one thing I would like to point out, though, you may notice our Hispanic residents are doing better. They're actually lower on almost every one of these indicators. And the reality is that they have protective factors in their community that overall makes them healthier overall. And we can see that sort of play out here. They have a much higher sense of community. There's a sense of a village, and we in the health department talk a lot about connectedness and how important that is. But then came COVID. And that changed, at least for our Hispanic residents. We see the same pattern for the most part. Our Black non-Hispanic residents, our Hispanic residents ended up in the hospital at a higher rate than our white non-Hispanic residents. They also died at a higher rate than our white non-Hispanic residents. And part of this is the same thing that truthfully protected our Hispanic residents of living in multi-generational households where there's that sense of village and that connectedness. Well, when somebody goes to school or goes to their essential job and comes home with COVID, what happens? It spreads through that household. So the elders of the family are more likely to get it and get sick with it. And this was particularly cute. This data is actually only 2020. So this is really reflective of what happened in that first year before vaccines were available. Now, Dr. Ariola already talked about this, but for me, infant mortality is one of the key markers for how a community is doing around health. And for every 1,000 live births, we're gonna see 3 white infants in Johnson County die before they hit 1 year of age. For our Hispanic infants, 4 of them will die. But when it comes to our Black infants, out of every 1,000 live births in Johnson County, 10 Black infants will die before they reach the 1st year of age. I want that to sink in because these are our littlest humans and no parent should ever lose a child. It's unnatural in the world. But this is not okay. Because the reality is racism is a public health threat, and we can see it very clearly when we talk about infant mortality. Because with infant mortality, we talk a lot about how education and income protect you, right? You protect you from bad health outcomes. You have access. You live in the best neighborhoods. You have access to the good schools. You have access to healthcare. It should protect you. But when we talk about infant mortality, maternal mortality, more than pretty much any other health outcome, what we see is that Black birthing parents and Black infants, even if they're born to families who are high income, highly educated, they are still at a higher risk of maternal mortality and infant mortality than white families who have a high school education. So let that sink in. We are told in this country that if you get an education, you can have good health, essentially. You can have access. But for Black families, that is not the case when it comes to infant maternal mortality. And Dr. Ariola talked about where we rank nationwide or worldwide. For infant mortality, we rank 33 out of 36. What does that say? It says that racism is a public health issue. If it's not solved by education and income and access, there's something deeper. So we're gonna go ahead and try and play this video here because I think that when we talk about racism, right, people are going to, in this room or in the community, are going to say, but I'm not racist. I'm not saying you are. What I am saying is that our systems, our history in our country and in our community are setting up our racist. Our systems are. And what that means is that people don't have a fair chance. Their babies don't have a fair chance to reach into the first year of life. So until we understand our history, we can't move forward to change the patterns and the policies. Hey, it worked. Let's see if we have volume, y'all.
It was really to help people purchase homes, unable depression after the war with the homes. So we back and married. I was summer groups from the first time, especially in the war. We were marching across the so the population corrected on real American chance for new generation to have known that people wanted these things to reach well to the provider. But they were playing very explicitly in that this is a system benefit like and so in order to qualify neighborhoods to know if they were worthy of getting mortgage insurance, essentially, the HOLC went around and appraisals and figured out what their range was. Green is the best brand new houses, all white populations, probably researching that to make sure it's safe. Like red would be in the smaller houses, definitely minority populations. We're probably maintaining over time on owning their home. So that wealth is generational building of property. Not everyone who's moving to something. The average person who understand issues of the certainly there were people who and some folks are seeing people who know that happening and they want something in the community where that won't happen. These restrictions have been around for a long time. They're used really in early 20th century usable properties to make sure that that property. There was a real fear that it's not busting the family itself and then the whole rest of the lot. A lot of the talk at the time is talking about home values and how home values plummet. And the FHA for providing proof that that was happening in a lot of ways. Today we look at the economics that most people actually the home values stay higher because you have African American families buying houses. So on the surface of it, it looks like Kansas City and Suffolk County is very typical of sort of playing along with it. But actually, in a lot of ways, Kansas City is beating suburban county, right? Because Jason Nichols is usually in suburbanization and building large scale neighborhoods and market to middle class families. He takes these things already in place, the racial covenant, and he says, you know, for a real estate developer, this is all And so he creates neighborhood associations, home associations, for his neighborhood. And he says, if you like, you can sign on all these bylaws of these companies. And one of those is almost always no African Americans in own, lease, rent, like this property. That's why we see and it's still over 80% white. Certainly there's more population moving in Chester County, and it's certainly a larger percentage of African American families. But these decades of restriction and undesirable place to live for the mountain, that hangs over there's a lot of pride in these policies up until the 60s, convention transition they're throwing out a bunch of changes. See, even though the things unconstitutional, it takes time for that to change because we're going to have to learn people, these students, and just because they're legally banned now, that means they have to use it. So, being they have to, there's a perception of this change as well.
Sorry, microphone would help. So I want to go. That was a wonderful video, and a big thanks to UCS, who did that in partnership with DHE and the Johnson County Museum. If you're interested in learning more about redlining in Johnson County, the Johnson County Museum at Arts and Heritage has a fantastic display. It's going to be up for a while. You should definitely go check it out. I'm going to hope that they get there we go. That's better. So the reality is that, yes, that was historical, but the reason why our community looks the way it does is because of that. And unfortunately, there's still evidence of issues in racism that affects our families, both in this county as well as throughout the country today. So these are some headlines that have happened. This most recent one was within the last couple of weeks, where a Johns Hopkins professor, they had done a lot of work on their house and they wanted to refinance. And so they got an appraisal and it was far lower than they thought it should be. So they whitewashed their house. They took down all of the pictures of themselves, anything that represented their Black culture, and had a white colleague go ahead and be there when the appraiser showed up. And lo and behold, their new appraisal value was $300,000 higher. And that's not the first time. And the reality is it's not just about home ownership and appraisal values, but it's also racism, and just systemic racism and biases also impact hiring, right? So we talk about, and we'll talk a little bit more about how our communities of color disproportionately make up the individuals in our community who live in poverty, but it's because of the systems in place that have put them there. And we see continued biases around hiring practices too. And what that means is that if we look at the per capita income in this community, for every $1 that a white non-Hispanic individual earns, Black non-Hispanic individual will earn 65 cents. Somebody who's of multiple races, which is one of our fastest growing demographics in this community, will make 50 cents. And an individual who is Hispanic will make 48 cents. What impact does that have on these families, on our community, and on our health? Because if poverty were a city in Johnson County, it would be the 6th largest. And it is true that our communities of color do disproportionately make up for themselves. Try that again. People of color are overwhelmingly in poverty because of these historical pieces. However, because of the way that our community is made up, if you look at the number of people living below the poverty level in Johnson County, they're overwhelmingly white, non-Hispanic. And the problem is, for anybody, whether you are living below the poverty level especially, but even low income, the reality is that the cost of living in Johnson County is very, very high. Again, we have the best parks and the best schools, the best neighborhoods. So for a single parent with 2 children, it's going to cost them a little under $7,000 a month to live. If you are low income or 200% of poverty, you're only meeting about 53% of those costs. And for those of you who don't do math in your head very well, that's about $42,000. And if you're living below the poverty level, you're only meeting 27%. That's about $21,000 for a family of 3 because the poverty level hasn't changed in decades. And that means that you have to make really hard decisions about what you're doing with your money. Can you afford to buy your prescription costs? Can you afford to put food on the table? And while this percentage of individuals in Johnson County who are food insecure is much lower than the percentage in Wyandotte County or in the state, what makes us really unique is that 6 in 10, which is much higher than those other communities, make too much money to be provided food supports. So they don't qualify for SNAP. Their kids don't qualify for free and reduced lunch. What does this do to our community? Another big cost for families is childcare. And especially coming out of COVID-19, we are in a childcare crisis. But childcare in this community costs more than a year of public tuition. And think about who is trying to pay for childcare. People earlier in their careers, people who have essential jobs, people with young babies. That's a lot of money to be spending out of your very limited budget. So what does this mean for us? It means that we're all, not all of us, but certain parts of our population, particularly our communities of color, particularly our people living in poverty and who are low income, experience chronic stress. We as humans were conditioned to respond to stress. If a bear coming at me when I'm a hunter or gatherer, I am running. My body is triggering and I am moving my legs as fast as possible. We don't have those kinds of threats anymore. But what certain members of our community have are day in, day out stresses about how they're going to feed their family, how they're going to pay their rent, how they're going to keep the lights on, how they're going to get their kids to school. And this stress causes all sorts of biological processes that make you unhealthy. The obvious ones, the headaches, depression, anxiety, those we all sort of can associate with. But the reality is physiologically, it leads to thickening of your artery walls. You're more likely to have a heart attack if you're chronically stressed. You're more likely to have diabetes if you're chronically stressed. You're more likely to be obese if you're chronically stressed because of hormonal changes that come from that day in, day out stress. And we see all sorts of impacts from the stress, from the need to cope. We have seen a massive increase, like most other parts of this country, in fentanyl deaths and fentanyl poisonings. But we can change. Nothing is written in stone. And this meeting, under Dr. Ariel's leadership around the Public Health Leadership Council, among all of us coming together, we can change and make this community healthier in 10 years. But we have to do it together. You all are the experts on education, on housing, on poverty, on criminal justice. We at the health department, we're some experts on data and telling stories with the data and understanding how data connects across these different systems and what we can do with it. We live in a community of over 600,000 residents. That's too much for us to say, we're going to institute this policy and we're going to change things. That's not what we can do in here. But what we can do is we can use data across our systems and find geographic areas or populations where we can start the conversation. And this is not DHE is coming in to save the day. What we want, what we see as our future is data initiated, community led. We need to be with partners, we need to be with our community members, and we need to be identifying things that meet their needs to allow them to live their healthiest life. So if you want any more information about data, I encourage you to go to our Health Happens Here website, which is our summary of our community health assessment. It's got lots of great data. We'll be continuing to update that. And we really appreciate you all being here. It's really great to see so many people rallying around health. So with that, I will turn it over to Aldana. Thank you.
So our next speaker is actually our keynote speaker. And I would like to introduce to you Dr. Paul Kuhnhart, who is the president and CEO of FAB, which is Public Health Accreditation Board, where he oversees all aspects of FAB's mission and work, including accreditation organization, related strategies, partnerships, long-range planning, FAB's board of directors, committees, think tanks, and student opportunities. His career expands nearly 30 years of providing executive leadership to private and governmental organizations to build and improve systems to address complex health and human services needs. Immediately prior to his FAB work in systems to, immediately prior to joining FAB in systems to address complex health and human services needs. And he worked for 7 years at the Robert Wood Johnson Foundation in Princeton, New Jersey, and most recently in the role of the Associate Vice President of the program. Prior to joining Robert Wood Johnson Foundation, in 2012, he spent 5 years as the County Health Officer and Executive Director for Health for Kane County, Illinois, a metro Chicago county of 515,000 people. In that role, he provided executive leadership and oversight to 4 county health departments in health, emergency management, community reinvestment, and animal control. Earlier, he served as Deputy State Health Officer and Deputy Director of the State of Maine Health Department. Dr. Kunar is a pediatric nurse practitioner and holds a Doctor of Nursing Practice in Executive Leadership, as well as a Master of Science and Public Health nursing degrees from the University of Illinois in Chicago. He was also named the Robert Wood Johnson Foundation Executive Nurse Fellow in 2004, a fellowship in National Academics of Practice in 2010, and fellow in American Academic of Nursing in 2015. As a fellow nurse, it makes me very proud to recognize and introduce to you your next speaker, Dr. Paul Kunar.
Thank you so much, Aldana. I am just taking a real quick check here to make sure that you're hearing me okay and you can see my slides. So it looks like you can. I will go ahead and proceed. And thank you all so much for the honor of joining you today. I wish very much that I could be with you in person. Unfortunately, I already had a commitment here in Alexandria, Virginia, where we're headquartered, and couldn't make the travel today. Couldn't be here and be there. So we lit upon this great solution of using Zoom, and I hope that it'll work well. I'm going to share a number of things with you today. This is kind of my outline of my presentation. I want to talk a little bit just in terms of my background and what kind of brings me into this conversation. Do a little bit more around setting the context, although listening to the previous speakers, I think the context is pretty well set. But then I really want to share some of what I've learned from colleagues around the country in terms of how we can approach both the opportunities and challenges that we're facing with trying to move health forward. So what steps can we take and how can we do that? So I'd love to start with this quote from one of my favorite authors, fellow Midwesterner, Mark Twain, who says, "The 2 most important days in your life are the day that you were born and the day that you find out why." And for me, both of those days occurred a few hundred miles east of you all in the city of St. Louis, where I was born, but also where I had my first experience in working in community health and public health. And when I had that experience, it really made a connection for me, and it has been my life's passion to work with communities to improve health. And my original inspiration actually came from this woman, Dr. Helen Bruce. And Dr. Bruce was our health commissioner in the city of St. Louis when I joined the health department in 1979. I was only 12, by the way. But seriously, Dr. Bruce was health commissioner, and she was very involved with staff, did a lot with our orientation, was very open and available to us. And I was able to learn a number of things from her. And just a couple of key lessons that I started learning about with Dr. Bruce was that, first of all, health is more than not being sick. And I think we've heard this already this morning when we kind of heard from Charlie talking about, understanding causes of death and how we've kind of changed our views on what causes health and how it's much more complex than we think. And then one of the other things Dr. Bruce really helped me start to learn about was this notion that we've been talking about already this morning, the social determinants of health, the upstream health factors. And that is that basically the choices that we make around our health are really based on the choices that we have. And so when we think about health that way, it's important to kind of remember where we've come from. And so Dr. Bruce was part of the generation in public health and public health leaders that was kind of the bridge between our founders in public health back at the turn of the previous century in the late 1800s and early 1900s, and then the generation of those of us that have been working past 35, 40 years in public health to today. And so her legacy, the legacy of her generation, was really continuing the trends of being able to address the major threats earlier in the 20th century from infectious disease. And you can see that in this trend line. But as we've been talking about, and as Charlie in particular really underscored, there was a transition. And we saw that by the late 1900s, and certainly by early 2000s, the chronic diseases really became the major issues that we were dealing with in terms of public health challenges. Now, we can't ignore the fact that infectious diseases are still a threat. And we've certainly learned that like we've never learned it before with the COVID experience that we've all lived through these past couple of years. And obviously this conference is not about COVID, but I think what we have to keep in mind are the lessons that we have learned from this pandemic, and we're continuing to learn. And some of them are really, important to keep in mind as we think about moving health forward in general. One of the things that I would say that we've learned is that we have a lot of work to do to build these bonds between our governmental public health workforce, the expertise that our governmental health workers have, and the community. We really need to address some of the trust issues and some of the communication issues that are going to be so vital as we move health forward. So it's important to keep in mind that while our overall drivers still continue to be chronic diseases in terms of causes of death as a result of the risk factors, as a result of social determinants of health, that we still need to really grapple with and be prepared for responding to infectious disease outbreaks like COVID. I think we're only beginning to understand the full dimensions of the impact of this pandemic on us. And this chart, again, from Dr. Wolf at Virginia Commonwealth University, talks about the loss of years of life, not only the loss of life, which is staggering enough. Another dimension, though, and we've already heard about kind of the larger context, is that even as we entered this pandemic, we were far behind our comparable high-income countries in the world. Now, these data are looking at life expectancy and cost. And so the United States is performing worse in terms of health outcomes, looking at life expectancy, but spending more than our peer countries. So we're getting worse outcomes for more money. This has only been exacerbated, and some of these data were already talked about. That trend was already happening by the mid 2010s, but now it's really been accelerated with COVID, and we're getting further and further behind our peer countries in terms of life expectancy as kind of an ultimate outcome measure. So again, just more context that we have so much work to do. And I'm so glad that Johnson County is taking this task on. Because when we think about it, and particularly for all of us that are deeply concerned about health, this whole trajectory that we've been on and our experience of the last few years has been absolutely heartbreaking. Heartbreaking in terms of the losses that we've experienced, not only loss of life, but loss of trust, loss of community, the mental health losses, the social and educational losses that our children have experienced. It's all absolutely heartbreaking. So what do we do about it? And that's really where I want to spend the rest of my time with you this morning. So what's clear is that we can't continue to approach these problems using the same kinds of approaches that we've used in the past. If we want to get different outcomes, we have to do things differently or do different things. And I would say that as we think about how do we move health forward, we have to remember it's not a technical fix. We do need to use technology. We do need to have our experts and our scientists along with us, but we also need to involve all of our hearts in this work, our spirits, and our connections with each other. So it's really a matter of making sure that we're moving together with both hearts and minds as we think about restoring, rebuilding, and moving health forward in our communities. So where we start, I would say, is that we have to build a common vision around what we're trying to get to. Now, the Robert Wood Johnson Foundation, for about the past 6 years or so, has had this culture of health vision as kind of their calling card, their focus, their North Star, if you will, that's guiding what they do. And I think it's a pretty good vision, this notion of, as a nation, striving together, enabling all to lead healthier lives now and for generations to come. But is this the vision for Johnson County? I think part of the work that you need to do is make sure that there's a vision that everyone is sharing, that you can rally behind, and that can be the focus and kind of the touchstone, the North Star as you go forward. The other piece that I think is really important is when we do this work, we do need to base it on our values. We need to lead with our values. And I would just offer 3 of mine that are important to me as examples. So these are kind of value statements that imply principles or values underneath them. But I think many people share these kind of values, and I'm just putting them out as examples. I think you need to kind of articulate the values and principles that your community has as you embark on this work. So I would suggest that one is around wanting our communities to be better places for all of our children and grandchildren. This notion that we really do believe that everyone should have fair and just opportunities to thrive, and that we have to listen and learn from each other and from the experiences of people around us, both within our communities, but also with folks around the state, around the region, and around the country and the globe, ultimately. So if we start there, then we really have to kind of figure out, well, how do we do the work of getting from where we are today, this heartbreaking condition, this heartbreaking set of circumstances, be it COVID, be it the deaths of despair, overdoses, et cetera. How do we move forward? And so this healthcare executive talked about being on the bus for population health, but really trying to think about how do we do things differently? Because our system is set up to really focus on sick care, not health promotion. And so I think there are really three key things that we have to do as we start on this path, as we build this pathway together. First, and what I want to do with the remainder of my time is talk about these and then give you a concrete example from other communities that are doing this work. So the first is clearly addressing these upstream factors. The second is that we really have to deepen our partnership with the community, with community residents and community leaders. And then we really have to look at the problems that we're trying to solve as not the responsibility of one sector of society, but really working across sectors to be able to solve these issues and make it possible for all of us in our community to thrive. So let's start by talking about this notion of addressing upstream factors. We've already heard, and I think everyone is familiar at a high level with the notion of social determinants of health. This idea that most of what shapes our health is actually outside of a clinical setting, outside of the hospitals and the doctor's offices. That health, in fact, is shaped over our lifetime, and it's shaped by many social and economic factors, some of which are kind of illustrated on the screen. In our communities, and as we saw with that very enlightening video about housing in Johnson County, our communities, the structures that we erect and reinforce through policy, et cetera, these are the things that really shape our health and well-being. But let's dive into this a little bit deeper. Oops. And now you can see I'm having a little trouble with my slides here. I apologize. This is always the worst possible nightmare, right? When you're on Zoom and depending on your slides to share some content. So I apologize for that. We just change the view here real quick. We'll get back on track. I have no idea what happened. But what I wanted to show you is this illustration of what kind of is the core factors involved in health and well-being, kind of in a different way than kind of the usual way that we think about social determinants of health. So this is based on really the World Health Organization's longtime definition of health as not being simply the absence of disease, but the presence of social, emotional, mental, physical, and spiritual well-being. So it's really this very comprehensive view. And what we know is that health is part of a larger ecosystem and is shaped and helps shape so these things interact with each other in terms of democracy, social justice, prosperity, and safety as being key factors. So if we think about social determinants of health and well-being, we can really kind of think about them in a couple of important dimensions that I think are really critical for you as you're embarking on your work to move health forward. Oftentimes, particularly in healthcare, we end up focusing on social determinants of health as kind of the need side of the equation. What are the social needs that people have? What are the urgent needs? And we don't as often talk about the vital conditions, kind of those background conditions, policies, and systems that are in the community that really shape the challenges and opportunities that people are experiencing. So the reality is that when we talk about addressing social determinants of health, we can't choose to just do part of this work. We have to do both work in addressing urgent needs and in addressing and improving vital conditions. So what might that work look like? Well, first of all, it's really important for us to remember that we're talking about social systems that start with individuals, but include the family and include the community. And then just as examples of some of the needs and the conditions that we need to address, we really have on the urgent needs side, all of the things that I think our health system and our social service systems are trying to address, and that perhaps have areas that in our communities we can improve. And then on the other side, in terms of vital conditions, we're really talking about the systems that are going to support people in the trajectory of their lives and moving toward thriving and well-being overall. So we really need to address both of these things. So I want to give you a concrete example from your neighbors in the Midwest, but a little bit north of you, with a really bad baseball team this year. And I'm talking about Minneapolis. So here in Minneapolis, there's an organization that's called Appetite for Change. And Appetite for Change is a great example of a community organization that's been built up over time and in collaboration with other partners in the community that's using food as a vehicle for social change. So they believe that when families reclaim the kitchen as a place to bond with and educate their children, that communities become stronger and more equipped for the struggles of daily life. So they kind of built on this concept. They went through a process. They did develop a set of guiding principles for their organization that are here on the screen. And they really put these into practice as they started their programs. And like I said, their programs now have been maturing for about 10 years. So let me just give you a couple of examples. They have a kind of health education program, but it's more than that. It's focusing on hands-on learning about and using resources together that they call community cooks to meet the unique needs of families and new and soon-to-be mothers, youth, and children. And they bring people together and do cooking together and learn about nutrition together in a very hands-on way. Another program of theirs, it's really kind of a flagship program for them, is urban agriculture. So they have what they call a Fresh Corners initiative where urban farmers in North Minneapolis are empowered to get their fresh produce into local restaurants, corner stores, and farmers markets, and building a local community-based food system and creating health equity. Another kind of key program that they have is the Breaking Bread Cafe and Catering. This is actually a business. They've created a restaurant in their community, which North Minneapolis is a very poor area of Minneapolis, and there's been kind of a dearth of new businesses and restaurants in the area. And so they built this as kind of a demonstration. It's community driven and community owned. They offer fresh, delicious, and wholesome food in this restaurant, in the cafe, but they're also using it for more. They're using it as a job training site and also an economic development site, because part of what they do is use this same restaurant, some of the space in back, for business incubation. So folks that are working on developing the catering business or other food-related business, like I mentioned, those urban farmers, they can use this space to prep their food and really use it as a hub for these food-related business ventures. They also have a focus on changing policy. And so they're leading a good food movement in Minneapolis, working with food ambassadors, as kind of shown here with these two young men, on food justice policy and advocacy issues. And through this, and through their other programs around employment and training, they're really doing things around developing youth leadership and preparing people for jobs and helping them find jobs and then get placed. So this is really an example of an organization that over a period of time, through developing kind of a vision, a set of values and principles, and then developing partnerships, has really expanded. And again, kind of starting with a health focus, has branched out and really is addressing many of these upstream factors that we've talked about. So the second area I want to talk about and give you an example is the importance of partnership with the community. I think we probably all buy into this value statement that we shouldn't be doing things for people without people being part of what's happening. So nothing about me without me is kind of a core statement. I think we would also probably agree that in many of our communities right now, many community members are kind of alienated from the larger community. They're not connected with their neighbors. They may not trust the government agencies, and they're suspicious of institutions. But it's not going to be enough for us to say, well, it's important to involve the community without really developing some strategies and some approaches to engage community members. So one of the things that we've learned in our work with communities and community-based coalitions is that we see these problems time and time again in terms of how our community partnerships around health often don't walk the talk. And I think it goes back to this notion of not being able to fully engage with the community. So what does it look like to do more robust community engagement? Well, it really has kind of these three key components. First of all, there has to be resident awareness and participation in services as kind of a baseline. There also have to be structured ways to get feedback and input from residents in the community about what you're doing as you're doing it in order to improve processes and policies. And then thirdly, and oftentimes this is not as actively supported, it's really important to involve residents in leadership of the work itself. And so what we have found and what we've seen from effective community health coalitions across the country is that they really do all three of these things in a comprehensive way. That's based on these notions that we really are kind of going back to some of the values and the principles that underlie our work. So I think everyone would agree that people need to have a sense of belonging. They need to have a sense of collective identity and cultural identity. That in fact, that sense of belonging to a community, to an effort, an initiative, is really vital to their sense of being able to have an impact on it. Secondly, there does have to be a sense of trust. And we know that low levels of relational trust among residents and between residents and local institutions is a huge barrier to effective engagement and making things work. And then thirdly, people do have to have a sense of power, a sense of agency. And if they're not really getting the sense that their word, their involvement is going to make a difference, then they're really not motivated to be involved. So how do we put these things into practice? And again, I want to share a quick example. So there's an organization in Cleveland, yes, and it's called Neighbor Up. And Neighbor Up is a project, again, started with community foundation funding in Cleveland. And it was kind of based on a community organization that already existed that's called Neighborhood Connections. So it was launched about a decade ago. And Neighbor Up is a membership organization that's very grassroots, but it brings together what they call unusual suspects. And what they mean by that is that they're bringing people together that might not otherwise kind of either socially or through work meet each other, let alone work together. So they build these networks that include folks from health and healthcare, as well as people from the community. And they use a set of networking practices and tools in monthly neighbor night meetings and other settings to feed aspirations and to unleash the capacity of neighborhood residents to address problems. So where they start is with these monthly neighborhood-based meetings. And again, they have a set of organizing and networking techniques, but then they're really driven by who shows up and how people get involved. Some of this work is topic specific. So for example, there's groups in Neighbor Up that are working on infant mortality or lead poisoning, but others are really driven by more immediate interests of what neighborhood residents bring to these meetings themselves. So they might be working on issues that have to do with how they address crime and safety and those kinds of things as well. What they also do, though, is really then build on these neighbor night meetings to create bigger networks and have impact on systems. And this is where oftentimes they're partnering with other institutions like hospitals, universities, and others, governmental agencies that are really trying to work on some of the systemic issues in Cleveland. One of the innovative things that they do have is they have the largest small grant program that I'm aware of, where they use some of their funds to make small grants of basically $500 to $1,200 to neighborhood residents. These grant decisions are made by committees of neighborhood residents, and the projects are all based in the neighborhood. And this is an example of one of those that was funded through this process. So again, an example of kind of deep engagement with community residents, how it's built, how it's sustained, and that there has to be kind of a set of tools that are applied and sustained, and a real deliberate approach to it in order to kind of make it happen. What's happened over this 10 years in Cleveland is that it started in one part of Cleveland, and now Neighbor Up and Neighborhood Connections really has a presence throughout pretty much all of the neighborhoods within the city of Cleveland. So one more area that I just want to talk about is building connections across sectors. And here again, this is driven by what we've seen and learned across the country in terms of our issues in these local connections. These coalitions oftentimes are very fragile, very unstable. And so here at the Public Health Accreditation Board, we have two divisions, the Center for Sharing Public Health Services and the Public Health National Center for Innovations. We received some grant funding from the Robert Wood Johnson Foundation to really explore best practices around cross-sector innovation. And we've recently published results from this 2-year project where we have funded 10 communities to really try to understand what were the essential ingredients and practices to make cross-sector initiatives effective. Now, you'll notice that this is dated right now. We just published this report. It was a 2-year project. And what I have to tell you is that the original project was different than what ended up being done because of the pandemic. But if you go to that website, you will find this publication that we put together with the 10 partnerships. And Cuyahoga County, again, this is the county that includes Cleveland, but it's not only Cleveland. So in many ways, it may be similar in terms of size and regional impact as your county, as Johnson County. And they brought together and worked on a health improvement partnership that involved 300 community agencies and 1,000 community members. Now they had a project in mind, and then the pandemic kind of intervened. And so what they ended up doing was really spending a lot of time working with each other to better understand what the impacts were of what we heard about earlier this morning in terms of systemic racism, and really trying to get underneath that and have these difficult conversations, but these vital conversations to really understand how systemic racism worked in their county. And so they used a tool set to kind of create these systems maps and have these conversations. And the results are here in this document. Just the last thing that I'll say about this important work around building connections across sectors is that across these 10 projects, what we identified were the key role that health departments played in the sectors, having these kinds of roles to support the cross-sector initiative. So being able to bring people together, as we heard earlier, the importance of being able to bring data that's relevant from your communities, and then really being able to facilitate conversations, and support the community in moving forward through the process. So again, a lot more there online. And all of you will have the chance to receive these slides. There's more contact information for each of the organizations that I've talked about if you want to follow up with them. And again, my contact information as well. But to summarize what I've shared with you this morning, I would just say that to move health forward in Johnson County, there's 5 key things that need to happen that we've talked about: creating a common vision, articulating the shared values and principles that will underlie and sustain your work, and then addressing upstream factors, partnering with the community, and building connections across sectors. And with that, I know I'm kind of right at, or maybe slightly over my time. I'll turn it back over to Aldana. I don't know if we have time for any questions or not. But thank you so much for your attention and the opportunity to join you. Again, sorry I could just do this remotely. Would have been much better to be with you in person. Thank you.
We have about 2 or 3 minutes for questions, if there are questions. So if Angela and Jennifer will have microphones. So if you have a question you'd like to ask Paul, please raise your hand and one of these ladies will bring you the microphone. Let us know if you can't hear the question, Paul.
Hey, hi, Paul. Somi here.
Good morning.
Thank you for the presentation. Can you talk a little bit about public health resources, building foundational capacity to carry out foundational public health services, and some of the work that you are doing about that?
Sure, I'd be happy to. Thank you. So what we've identified, and when I say we, I mean the public health community broadly, is that there's a set of kind of foundational capabilities that every community must have in order for public health and health itself in the community to be protected and for communities to thrive. And these foundational public health services are, then the foundation for specific programs that the community wants to have in order to address its particular needs. So let me just give you an example, and I think you've seen it already this morning. One of those foundational capabilities is around epidemiology and surveillance, being able to gather data, look at it, analyze it, and then share that out. Another foundational capability is the ability to communicate effectively about these health data. And then just another example would be a capability that a health department needs to have around convening and building partnerships in order to address these complex issues. So what we're doing is working with systems in 18 states at this point. We hope it'll be 21 soon. In this learning community that Kansas has been a part of from the very beginning. So we've had this learning community for the 21st century public health since 2015. And states are learning together about how to best organize and foster these foundational capabilities and bring resources to bear so that, again, your community has them, but also your neighboring community has them. Perhaps you share some of the capabilities with each other so they're not being duplicated. But then statewide in the state of Kansas, you would have that those capabilities to protect and promote health across the entire state.
Probably have time for one more question. Is there another question? We got one in the back of the room.
Thank you. I had a question for Dr. Kunert. Thank you for your presentation. And I appreciate the examples that you gave of different communities that are doing different things to address public health issues. Can you talk about if are any outcome data from these various programs and what approaches seem to be most effective? Thank you.
Sure. So I think, you know, the outcomes that we're seeing initially, so for example, with appetite for change, are not seeing impacts right now on things like longevity or disease states immediately. What we see are some of the indicators that we hope would lead to those kinds of ultimate health outcomes that would include increases. So particularly with appetite for change, being able to see the actual delivery of more fresh food in a neighborhood that previously never had it. And so you see it with farmers markets, with food trucks, with you know, some new food businesses that are making food more available, healthy food available. And then you also see kind of indicators of engagement and particularly by young people in the community, learning leadership skills, job skills, getting jobs, and then really kind of putting themselves on the trajectory to what we would believe would lead to these better health outcomes. But I think what we're seeing is it takes, you know, 5 to 10 years to build these initiatives. You start seeing those kind of indicators of progress, but health outcomes on a population level are probably going to take another 5 years beyond that. But I think the indicators are pointing to what we believe would be a change in some of those health outcomes, whether they're things like diabetes rates or rates of obesity or overweight and those kinds of things.
Okay, thank you very much. In order to try to stay on schedule, thanks again, Paul. We really appreciate you being here.
Thank you for the opportunity. I really enjoyed it.
Okay, now we're going to be moving into our networking break. So there are beverages available for you over here. I think it looks like there may still be a few leftovers from breakfast, but we do encourage you to take the time to add your comments to the feedback boards that are located. There's 2 in the back. So it's basically 2 whiteboards per topic. So do take a chance, grab some sticky notes. You use the questions. Please provide us with feedback. Fill your coffee, go to the restroom, whatever you need to do, and we will be starting back promptly at 10:45. Thank you.
We have until 11:45. Okay, so, yeah. I don't think we do that here, do we? Oh, that was, yeah, 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 that was really good, yeah, yeah. Hello, hello. Is that all? If you can, please start. It's not on yet? Okay. No. I think they just need to turn it on. Please start making your way to your seat so we can begin promptly. Thank you. I do want to. I think there were a few people that we tried to recognize earlier that weren't here, and I'm not sure that they're still here. I know that I saw Mayor Michelson here. I don't know if he's still here. And okay, I also do want to recognize Joe Connor from the county manager's office. Is Joe in here? Okay, he's outside. Okay, Joe has just been incredibly supportive of public health. Anyway, we would go to our next session, which is a panel conversation building on some of the things that we have talked about earlier. Just to reiterate, the goal is for everyone in the county who live, work, learn, play, here to have an opportunity to be as healthy as possible. That is our goal. It is to create healthy conditions everywhere. And we are moving upstream, focusing on those factors that if we address appropriately at the right level, we know can determine the outcome, which is a shift from damage control mode that we typically do. And we know that we can't do that without all of you. We can't do that without our cities. We can't do that without our elected officials. We can't do that without our community organizations. We can't do that without you. And so that partnership, I think Paul also really emphasized the importance of community engagement. So our panelists today are highly engaged members, respected members of the community. They represent very important part of public health. They represent important organizations and key efforts in the community. They have been part of partnerships and organizations. They have vetted partnerships and organizations. They are very well integrated into the community. They understand the community, which is a very important piece of what we're trying to do. And they represent different sectors of the community. Not-for-profit organizations, government, faith-based community. So today, they will help us get deeper into understanding partnerships. And we'll talk a little bit about some of what we need to do to bring people to the table and to keep them engaged. Again, I'll digress. I just saw Joe Connor. I recognized you earlier. All right. So I will start with Julie Brewer with the United Community Services of Johnson County. She's the executive director. UCS is a non-profit focused on poverty and health and human issues impacting Johnson County residents. The housing work that Elizabeth talked about, equity work, all of those were facilitated by UCS. Now, I do want to just recognize how well they work with us during COVID in reaching our communities. Again, UCS focuses on poverty and health and human services issues impacting Johnson County residents. Core work is illuminating needs and solutions through education and advocacy, fostering a framework for mobilizing and planning, and prioritizing community investments through targeted resource allocation. UCS recently facilitated a multi-sector community collaboration with area jurisdictions to address the priority of safe, stable, and attainable housing, which resulted in a housing study and toolkit. Next is Tim DeWeese. It's impossible for me to turn on social media and not see Tim there, which is really good. That's what public health is about. It's about being in the community and engaging the community. Tim is the director of the Johnson County Mental Health Center, which is a department of the Johnson County government and employs more than 360 staff who provide behavioral health services to nearly 12,000 county residents every year. Tim possesses a Bachelor of Science degree in psychology from Missouri Southern State University and a Master of Social Work Administration degree from the University of Kansas. He's a licensed mental health professional in Kansas. He has over 30 years of experience in community mental health, where he has worked in various capacities. He possesses extensive knowledge and experience in the public mental health delivery system, client-centered leadership, and program design and development. Tim also served more than 10 years as a commission officer in the Army Reserve and National Guard. Next, I will introduce Dr. Sophia Khan, KC for Refugees. She is a local physician. I met with her during the COVID prep also. So Dr. Khan moved to Greater KC from New York City over 25 years ago. She's a community activist and the interfaith leader involved in numerous charity projects for over 15 years. She's founder of KC for Refugees, a non-faith-based community alliance helping locally resettled area refugees. Her non-profit advocates for refugee settlements and provides community education on refugee-related topics. Besides providing support, it also helps build bridges between these families and the community. She's the recipient of 2016 Christian Peace Society Peace Award, 2017 Greater Kansas City Interfaith Council Steve Jeffers Leadership Service Award, 2017 United Nations Association of Greater KC World Citizen of the Year, 2017 Rhyme Buddhist Center Bodhisattva Award, 2019 American Pakistani Physician National Association KC Excellence in Service Award. She also serves on the board of American Public Square Islamic Center of Joko Interfaith Board. And last but not the least, Brenda Sharp with Rich Healthcare Foundation, where she's president and CEO. She served in that capacity since 2004. The Rich Foundation's mission is to advance health equity through coverage and care for underserved people in the Kansas City region. That's public health. With more than 30 years experience in the nonprofit sector, Brenda enjoys her skills to strengthen the leadership and governance capacity of organizations, institutions, and systems to better serve vulnerable population and to effectively engage in public policy advocacy. Brenda recently concluded service on the board of directors of Grantmakers in Health and has served as trustee on the board of a regional nonprofit health system, as well as the Kansas State Board of Healing Arts. Believing that the business sector engagement is essential to advancing health equity and sound public policy, Brenda currently serves as a board member of the Greater Kansas City Chamber of Commerce and the Downtown Overland Park Partnership. And in the question, will you have me welcome the panelists? Right, so I would begin with the question that all of you can address. We'll start with Julie. So for those in the room that are less familiar with your organization, specifically on efforts in engaging partners in the community, so that we are all on the working on the same page, tell us what the importance of partnerships are towards achieving specific goals and all your efforts towards creating authentic, sustainable engagement of interested parties and stakeholders.
Well, first of all, I'm glad you began with such an easy question. And then that she started with me.
I'm sorry, Julie.
No, that's all right.
I thought we agreed that we're going to make it difficult. Right?
You know, I'm going to start with an example, a piece of work that folks, I think many of you, well, I'm proud to say many of you in this room have been involved in, and many of us are impacted by. Actually, I would say all of us are impacted by, and that's around safe, stable, attainable housing in our community. Because if we don't have that, it really impacts all of us and the vitality of our community. So a good example of when we talk about building a table, I think the first thing we have to say to ourselves is we are always setting that table. It's not a finite table, right? And so when we began this work, we began with gathering people to the table. At that point in time, it was through Kansas Health Foundation Healthy Communities Initiative grant. And we were tasked with setting a table and then identifying through listening and research a priority health issue. And that ended up being housing. So we started with gathering, then we moved into listening. And we knew if we wanted to be intentional in listening, that it wasn't our table that we bring people to. It was their table that we went to. And we did that for many months. Our lead staff person who's in the room, Catherine Evans, was at the resource library with a listening table. We were out at congregate meal sites listening. We were at different Rotaries, Lions Clubs, you name it, listening. And it took the research. We're also grounded in our research and data. And from all of that came the visioning and the planning and the implementation. One of the things I love that Dr. Kernick shared earlier in his presentation around community engagement, it made me thoughtful. How did we do our community engagement? We started around that resident awareness with the building the narrative, lifting up the stories of people who were impacted in their housing, employers who are impacted by the housing issue, city governments, utilities, infrastructure, teachers, those who educate us, those who care for us, those who protect us, and what does housing look like as a factor in their lives. Then we moved to community and resident engagement through the housing study and the resident survey and the task force. And now we're moving on to leadership in act of our goals that came out of that. And it's a shared study because we had 19 communities in the county all invested saying this is priority work and have taken it on. The Board of County Commissioners has formed a housing subcommittee. We have cities that are reopening or redoing their comprehensive plans, forming housing task force. And we're doing our part by how can we equip residents who want to be more engaged with the confidence and the information to determine what that engagement looks like. And so we're working towards a pilot on that. So that's kind of that approach of how do you create a table. It's not just the tables that we set, but it's the tables that we go to. The difference.
Thank you, Brenda. Same question. If you want me to repeat that?
I think I put it in my notes.
Okay.
So I'll try to give it a shot. Well, thank you for being here. And it's really an honor to be with all of these individuals on this panel who are doing incredible work in our community. And essentially, that's what I would say the Regional Healthcare Foundation is about, is supporting the organizations, people in this community that are working every day to make our region more equitable in terms of health outcomes. So kudos to all of you in this room. And I see many friendly and long time face friends that we've enjoyed working with. One of the things that I would say is important for REACH, which is a health philanthropy that serves 6 counties in this region, Cass, Wyandotte, and Cass, Jackson, and Lafayette on the Missouri side, Johnson, Wyandotte, and Allen on the Kansas side of the state line. And we were created as a health conversion foundation almost 20 years ago when the former Health Midwest Hospital System sold its assets to HCA. So you may remember that transaction if you've been in the community for some time. Our vision is that all people in our communities achieve equitable health outcomes, and our mission is to advance health equity through coverage and care for underserved people in our region. We are all about partnerships and investing in those kinds of partnerships. And although we're a really small team, I just have a staff of 7, including myself, we try to be everywhere in the community and that we can. So just this week, our staff and board members have been engaged in the Health Equity and Inclusion Conference that's going on down the road, the Kansas Hospital Association Conference, Kansas City, Kansas Chamber Candidate Forum, and Communities Concerned with Immigrants and Refugees, which is an institution that we founded several years ago. We have board members with a very diverse set of backgrounds and skills and lived experiences. That's particularly important to us. We want to know if we are to be trusted in the community that we have on our board and on our staff who look like people and are people who have experienced what it's like to live without health insurance and health access and to have struggled with disparities. And that's critically important to us. And then I would say our goal is to extend our impact beyond writing checks. And I think a lot of people see us and think, gosh, you give away $5 million a year. That's a ton of money. That's amazing. It's the greatest job in the world. It is the greatest job in the world. It's hard to give away $5 million well, and especially when you have about 10 to 20 times more requests of that every year. But that's why it's important we're speaking with and talking to and understanding our community. And ultimately that we are looking at the data and we're looking at and understanding where those disparities exist in our community. So we also try to leverage technical assistance and support and engage consultants like the amazing Catherine Evans, who's in the back of the room, who's worked with us on our Centering Black Voices initiative to fund Black-led, Black-serving organizations more equitably than we have in the past. We try to listen to people who are really tapped into their community. We know that as philanthropy, we're endowed with some level of presumed privilege that isn't real, isn't deserved, it isn't earned. And I have to fight that every day in this position. And a lot of people don't know about the background that I grew up in as a very low income individual in a rural community that struggled with all of these issues that we're talking about. But I still had privilege. I still had things that other people didn't, that I didn't deserve just because I was white and I embraced the education system and I was a quick learner and those kinds of things and had some family supports that others don't. So I think it's important when we talk about all of these issues, and the stuff that resonated with me really this morning was around how much we have to fight a perception in our community that all is well, that everything is okay. It's working for a lot of people. Don't get me wrong. It's not working for a lot of people in our community. And it's time that we have some honest and authentic conversations about race and racism, that we understand that all of these issues are linked very closely: education, housing, transportation, socioeconomic status, that we are including people with lived experience in these conversations. And I would challenge us to even look around the room today and say, have we done that successfully today? It's better than rooms I sat around in Johnson County 10 and 15 and 20 years ago, but it's not good enough. We're not there yet. Last, I would say that one of the things for us to grow, and I was really intrigued by the conversations and thinking about us moving health forward in this county, we have to understand the changing demographics in this county, in our state, in our country. And we have done a lot of work at Reach around the US Census. We supported it. We have been following very carefully what's happening. And it may interest people to know in this room, and maybe you already know, that all of the net population growth in the state of Kansas has come from immigrants to our country. All of it. And immigrants bring with them ideas and really amazing passion and entrepreneurial spirit and educational backgrounds that are different than ours, that were born and raised here. And it's time we embrace that and understand that and own that and encourage that, and think about us differently than maybe the founders of this county and some of these communities thought of this, of what we would look like today.
Thank you. Thank you very much. Dr. Khan, same question.
Okay, so, my community is very diverse. Both, if you look at just the Muslim community, we have probably by now 3 Islamic centers within Johnson County. Within our community, we have 40 plus different nationalities, easy. From all continents of the world, immigrants, also people who helped build this country, those Muslims who are here for generations. It's a very diverse. I continue to learn from them. you have to be very humble. You have to learn how to listen, and you have to work with leaders within, sub-leaders within the community, recognize people who very humbly, very quietly are doing a lot of things within their little pockets and have a very high level of respect. And you need to use for leverage, liaisons. Same goes for the refugee community. For the same reason that we all want to live in Johnson County, as soon as these people become stable with their finances, they all want to move to Johnson County. And we have slowly growing population of refugees within the Johnson County area. So their needs, again, I have to listen to them to understand their needs. They could be really wide. I mean, you're talking about a specific for all Americans that maybe works for them, but for me, every person coming from which part of the world they're coming from, what was their culture there, what was a taboo for them, it's pretty difficult. So I think a lot of work that I have to do as part of, and I'm really proud to be part of this group, is to also make the health department understand the needs of this community. Communities, for example, if you look at the large number of Afghans that have moved, they are very different than the typical refugee population that has been moving to this country. Reason? Refugee relief work for the United States has been considered humanitarian work, which means they would pick out the most sickest people out of the refugee camp with a lot of complex health problems, sometimes disorders that are so rare you can't even find them in typical textbooks. Those kind of complex health problems was a typical population of refugees I've been working with for over 1.5 decades. But with the Afghans, they're young people. Typically, young, healthy people don't come as refugees. They are, no, you're not going to go. I'm going to take the elderly mom with the metastatic breast cancer. I'm not going to take you, right? But these were soldiers who were working with the army, and they came for that reason. They were just leaving the country and they were taken out. So now we have a different population to deal with. A lot of women getting pregnant. Every month I find out somebody's pregnant, having babies. People who have never had preventative care in their life. They don't know what preventative care means. They know that if I get sick, I see the doctor. If my herbs are not treating me, I wait a few days and see. If nothing is helping me and my village doctor, whatever the credentials might be, cannot take care of it, and I'm really dying, is when I actually go to the hospital. There's that concept. No preventative care, no prenatal care, no maternal care, no postpartum care. So to educate the communities first as to, you really need this. You need to get vaccinated for certain stuff. Once you find out you're pregnant, you have to start seeing somebody. So it's a very complex world that I live in, very different from what I do at the hospital. When I go and do my social work, I have to be ready to, again, sit on the table, listen to everybody, because, I'm from Pakistan. My culture was different. I grew up in a large city, very typical medical care like here. But for me to understand what goes on in refugee camps or in different parts of the world when you're a Muslim coming from different cultures. So I hope I can bring that education to the health department, and then understanding what the needs are in my community. I hope I can tap into the health department. For example, I was at a conference this weekend, an Islamic conference. Our family goes there once a year. It was after 3 years that we went there as a group. And I learned that teenage suicide is the highest among Muslim kids. And that was like a bomb in our face. My husband is a psychiatrist, and he's the president of the board of the Islamic Center as well. That we need to educate our community about teen suicide. It's a taboo topic. We don't talk about it. We don't talk about depression, especially with the immigrant population. Kids are not bringing it up with their families up until the point when they commit suicide. So a lot of ways that, these minority communities can be served by the health department. Really looking forward to this work.
Thank you, Dr. Khan. There's a lot of good things that the three of you have said. I'll come back to some of that, but I think your talk about teen suicide then takes us to Tim for his response to the question.
Well, thank you. So the Community Mental Health Center, Johnson County Mental Health Center, while we are a part of county government, we are our community's community mental health center. And as such, we really have three primary responsibilities. The first and foremost responsibility is to those individuals who have serious and persistent mental illness, both kids and adults. And the second is to be able to improve accessibility for those individuals who are experiencing mental health or behavioral health crisis. So those individuals who are in crisis and those individuals who have serious mental illness. That's our wheelhouse. I think the other piece for me, when I became the director, I've worked for Johnson County Mental Health Center for more than 25 years. And as over the years, I think what the focus for us has been is not only should we focus on those individuals that are in crisis and those individuals that are seriously mentally ill, but we also need to be the gateway or the front door to our community for mental health services. So we may not serve everyone in our community, but we can connect people, build that bridge that Dr. Ariola talks about to our community so that we can ensure that through the partnerships that we develop, that everyone has access to good mental health care. That's a challenge. We said it earlier, there is no public health without mental health, and there's no good mental health without public health. The interesting thing about the mental health system is that it's like the rest of the healthcare system in some ways. It's very different. It's not seen the same, but in some ways it's exactly the same. It's built on a responsive framework so that we're waiting for people to have illnesses. And what we really have to focus and move away from is that notion of responding to mental illness, but really focusing on mental well-being, mental wellness. And so how can we prevent major mental illnesses from occurring? And we do that by building resiliency among ourselves, within communities, reaching out to communities. It starts with showing kindness, understanding, and tolerance to one another, and the differences that are actually the strength of our communities. And so I think from a mental health perspective, when we talk about what do we do, from my perspective, it's about partnerships. It's about the work that we do with the public health department. It's about the work that we do with all the other county departments. It's about the work that we do with the cities. It's about the work that we do with the school districts, whether you're talking about youth suicide and 0 Reasons Why. It's about community partnerships, building authentic human relationships that will be the catalyst to move us forward in our community and make us more healthy.
Thank you, team, and thank you, everyone. I'm watching the time, so I'm going to skip some of the questions that I have. So I have some specific questions. I'll start with Julie. If you will just dive a little bit deeper into the different partnerships that your organization facilitates or are a part of. If you talk about how you started, you were going on that path, and how you engage participants, how you bring those who are typically not at the table, how you bring them to the table. Brenda did note that we could do a better job and bring it more diverse. How do you bring people that are typically not at the table? I tell people all the time, if you ask me to be somewhere, I will be that. That's what I'm paid to do. Now, if I work at McDonald's, or I am a parent of a 4-year-old, if you want me to be at the table, it will be at the expense of the money that I will be making working, which could mean the difference between rent and 3 square meals, and not to talk about childcare needs and those things. So how do really people that are typically not at the table, the marginalized group, how do you factor those commitment to equity and diversity to in your groups.
Absolutely. And a little bit about UCS, we're going on 60 years and we come old and we come out of that kind of regional planning concept. We predate the Johnson County Child Care Alliance Council predates the WISE Park and the Johnson County Park and Recs child care programs. We come out of this history of three core areas. We're not a direct service agency. We're research and advocacy, meaning and planning, and we're resource allocation. And it's really that research and data that a lot of people know us from, right? And that allows us, as we're building partnerships, to enter that door and start the conversation. We work with our cities and our county on the Human Service Fund and the Alcohol Tax Fund, doing the grant review and recommendation work. So many of our jurisdictions know us from those relationships. And then with the convening and planning work, we're able to set the table and create the space for groups across multiple sectors to come together, take a breath, and be thoughtful of what are emerging gaps or trends in our area that we need to address. But we recognize and have recognized over time, once again, that it's not just the table you set, but it's the table you're at and you're out in the community. We have also recognized that if you, as we heard earlier, that people want to have things done with them, not to them. They want to be at the table. So what does that look like? That looks like recognizing things that Dr. Ariola has highlighted. For instance, we're also the lead agency in convening the continuum of care on homelessness for Johnson County, and we work on the collaborative grant that brings to HUD that brings in the dollars. Well, part of that work needs to be connecting with those who have experienced or currently experiencing homelessness. Now, that's important. Not that arc of term. Someone experiencing homelessness is something they're going through. It isn't who they are. So that, first of all, in developing trusting relationships, is going into those relationships with respect and a level ground. So recognizing that we wanted those voices at the table, we also have to recognize many of us are here today. We are being compensated for our time to be here today. It's a part of our job. When we are talking to folks and want to learn from individuals who are impacted by an issue, we're asking two things of them. We're asking them to be a part of the process where they're not compensated as a part of their job. And we're also asking them oftentimes to be engaged in issues and subjects and discussions that are traumatic, right? And so I think we have to be thoughtful of that. So it's the dignity, it's building the trust, it's compensation. We are so thankful. We work a lot with the Reach Healthcare Foundation and Health Forward Foundation and other funders who are recognizing the importance of the voice of individuals who are impacted on an issue, and also the importance of compensating, of providing childcare, of making sure that if you have folks for whom English is not their first language, or who have a hearing impairment, or whatever those barriers are, transportation access, all of these things have to be a part of that intentional planning. It's going into the communities, not inviting people out of their communities. As Dr. Khan shared, it's understanding community and grassroots and neighborhood leadership structures within communities and respecting that and asking for them to provide that advice and conversation and guidance. Dr. Khan is someone that we pulled into some community work that we were doing with the Johnson County Department of Health and Environment when we were being thoughtful around vaccination, around testing. And then that has broadened into other health equity issues right now, maternal health issues. And probably the other example I'll give is being thoughtful about, and I just lost my train of thought, so I'm just gonna stop there.
That's okay. Thank you. You've shared a lot of really good things. I think for me, one of the bigger things is understanding the community from Dr. Khan, but also, like you said, intentional planning, going into the community, not necessarily making them come to us, and talking about the need for compensation and the trauma and all of those things.
I'll share one.
See, I
story.
thought about, kept talking, so you come up with that
I
idea.
knew it would come back.
Yeah.
Another wonderful resident here we connected with is in the process of trying to connect with around vaccination and testing. Really appreciate the health department's intentionality of recognizing there were members in our community who had very high barriers for access to testing and vaccination. And so I was out volunteering at a food distribution site at a church, and the volunteer who organized that was amazing. She had, everybody knew her. She knew what she was doing. She gave us all jobs. Boy, we were on tack. I thought, this is a community member I would love to have at the table. But, you know, I got that community member to join our table because I was willing to be out at her table, right? And listen and see her in action and see where her passion was. I think that's really important too, is sometimes we identify people as, oh, I need them at my table, but we haven't asked, do they want to be at the table? How does my table align with their passion? How can we work together so that we're both achieving results in our area? So that kind of connectedness is also very important.
Thank you. And I'm glad you brought the conversation around the partnerships and collaborations that it took to mitigate some of the more serious consequences of COVID infections. Now, so I'm going to go to Dr. Khan here. You worked with us. Part of our efforts, I had a similar conversation with you as I did with Julie. And, you know, when I spoke with Julie, we haven't met in person, but it was like, okay, should I just go with it? I got like, Julie, please. Same thing with you, with your community, and our model with the community health workers working with the population that you represent. We want to talk about that kind of partnership and the impact on the goals that we're trying to achieve.
Yes. So during the COVID crisis, we had a few vaccine clinics. I had several for the refugees too, working with University Health in Missouri. But we did specific to the Muslim population, Islamic community. Here at Johnson County, we had the healthcare workers come and give vaccination. And the interesting part to that was not just that they vaccinated people who were not vaccinated, but because it was at the center, somehow there were several people who were completely anti-vaxxers. They were not going to get a vaccine. But just because it was going to be at the center, those people at the last minute changed their mind. And they got the vaccine, and you guys came back and gave the boosters too. So we had a very successful event. And I was more thrilled to see those people that were reluctant to take the vaccine, take it just because it was happening at the Islamic Center. And then we also received home testing kits several times, which have been very helpful and very popular. And it has really helped keep those people who might be reluctant to go to CVS or stand in a line to get the test done, do the test and isolate themselves so they do not expose other people in the community. And because of efforts like that, our center has been very blessed that we had no outbreaks, like someone suddenly told us they attended the congregation and tested positive. We have not had any issues like that. So we are very glad for that collaboration.
And that efforts led to a sustained partnership with our team. I know the acronym is FACE. I don't know if Megan or Barbara can remind me what FACE stands for, but we are continuing those conversations. And I remember you and I talking a couple of weeks ago. One of the things that, and I'm paraphrasing, is the community, because of that engagement, feels valued, feels like somebody cares for them, when in the past they feel like nobody does, because they had access to testing, they had access to vaccination. And those kind of efforts, it's really what we are trying to make sure that it becomes a huge part of us. And so I'll go to Brenda. Rich, very active in the community. You support several initiatives. 5 million is a lot of money to me here. All right, so I'll ask you the $1 million question, literally, since we're talking $5 million. What kind of extra resources and efforts does it take to build the right sustainable partnerships that we need to move health forward in Johnson County? How can Johnson County creatively fund them? And what additional resources do we need?
Thank you for the $1 million question. A former colleague of mine, some of you may recall Steve Rowling, who was the former CEO of Health Forward, was fond of quoting his old boss, Ewing Kaufman, to say, money doesn't solve problems, people solve problems. And to that, I would add good policies can also go a long way to addressing longstanding problems in our community. A lot of what we do sometimes is revisit and reform bad policies that were designed primarily to support the white and the wealthy majority. And I think that that is critical. The other thing that I would call out in Johnson County, being a longtime Johnson Countyan, but working regionally and working in 2 states, is that regional planning is also necessary in a community like the greater Kansas City metropolitan area. Johnson County, quite frankly, is often missing from some of those regional conversations. We work a little bit on an island out here, and it's really important to remember and understand that people work and play and live and shop and have childcare and go to school in all parts of our community. And those county lines and the state line don't mean a lot to us in most of our everyday lives. We're all better together. And so we're interested at REACH, and I know my colleagues at Health Forward and many others are interested in regional efforts that lift up this whole Kansas City area. The other thing we're very fond of, and that we've enjoyed our partnership with the Public Health Department, is that public-private partnerships are very effective strategies to build sustainability. There is not enough money in all of combined to solve these problems. We have to have government involvement, we have to have legislation, we have to have local policies, and we have to leverage the private dollars and the government dollars every chance that we have an opportunity to do that. And then advocating for fair tax policies. I think this is something that we have lived firsthand in Kansas, and Missouri is about to tackle some of these same questions and opportunities as to, are we going to tax the lowest earners amongst us at a higher rate and percentage than those who are making significantly more, and expect them to move up in those charts that we saw earlier in terms of their ability to attain housing and food and medicine and health coverage. We really need fair tax policies to build resilient communities.
Thank you, Brenda, for answering the $1 million question. All right, team. There's a lot of work going on in the mental health arena in the county. Again, I mean that last few times there is 0 reasons why. Give me 20. Recently, there was something at the Blue Valley School about mental health, and you mentioned earlier the importance of the population health approach, the upstream approach, not just doing damage control, but looking at factors, upstream factors that we can impact to change and minimize this increase in mental health issues. If you will just talk about what's going on in the county, the partnerships that are critical to these efforts. Again, understanding that health, we need to be mentally, physically, socially, emotionally well.
So one of the things that I learned early on in my career is, and I read the information and I heard the data, and the data is that people that have serious mental illness died 25 years younger than the general population. I read that, I knew it, I could quote it. But when it really started to hit home is when I was a case manager, or when I was a clinician, and people that I worked with started dying. And they died of preventable diseases. They died because they didn't seek primary care. They died because they didn't have access to that care. And so for me, it's not only about us responding to the mental health crisis, it's about helping people respond to their overall health. Again, I can't think it can't be said enough that there's no mental health without health. We have to focus on our health. And so I take that one step further in that there are a number of things. One of the things that I've also learned in the years at Johnson County Mental Health Center is that many of us work with some of the same people, and we work in silos. And that while there's not enough money to go around, that if we remove those silos and we find ways to work more efficiently, that we develop good policies, remove those policies that disenfranchise or eliminate access to certain groups, then we can find a way to move and improve the health and the well-being of all of Johnson Countyans, not just those of privilege. You know, and I speak of that primarily because from a mental health standpoint, the mental health system itself, psychiatry itself, has not necessarily been the most understanding group. It's not been the most open group. And in fact, it's probably been one of the more racist groups, the field that I chose to go. And all you have to do is go and look at the history of psychiatry and mental health and see that. We have a long way to go within the mental health system, within the mental health organization, the mental health department at Johnson County, to reach our full community. It's changing, we have to change. But as a whole, we have to develop those partnerships. There's one last thing that I continue to hear, and you know, it always amazes me in that in these days of technology, and we tell ourselves that we're connected, and everybody tells us that we're connected. And in fact, what we're talking about is finding people's time. We're competing for people's time. You know, these have figured out how to compete for our time. They're very good at it, and they make a lot of money doing it. The fact is, in my mind, what we have to do is put that technology down and get back to developing those authentic human relationships, being at one another's tables, hearing the stories that everyone has, and understand that we're all impacted by mental health conditions, by physical health conditions, and how can we work together? You know, we talk about being connected, yet when you talk with folks from a mental health perspective, we're actually the most disconnected that we've ever been. And I think that is where we can make a difference in our community. It's through this group, through organizations like this, coming together, having these conversations, and having some at times difficult conversations, but being able to look one another in the eye and being respectful of one another, and then being open to hearing what those folks have to say. And I think that's how we make a difference, not just within the mental health system, but in overall health. If we have a healthy community, then we're going to have a mentally healthy community. We're going to have good mental health well-being.
Thank you, team, and the panel. You talked about your experiences, focus, and really did tell us some of the things that worked for you and some of the things that we need to continue to work on. So let's come back to everyone and really get to bringing this back to our current efforts is how do we build on all these things that are going on in the county? How do we build on our current efforts so we can have stronger, sustainable partnerships, trusting, authentic relationships that you all talked about? To start with you.
Well, I think the first thing is that, you know, I think we have to listen. We have to listen listen to what people are telling us, what our communities are telling us. And I think that then we can begin to develop those partnerships. Again, I think that for so many situations, there are these silos that we work within. And so if we can find a way to work outside of those silos, work together, then I think we can do that. It's about shifting the mindset from competition to collaboration. The fact is, though, we are prepared from early on, kindergarten, to be competitive. It's in our nature. And so we have to set aside that competitive nature and say, how can we come together to collaborate as opposed to compete with one another? Put that aside and move things forward for the greater good. How many times I work with a lot of youngsters right now in the work that we do with the school districts, and I hold a lot of promise because I hear young people talk about collaboration. I see young people interacting with one another. They know no color. They know they respect one another's experience, and most of all, they're willing to help one another and for the greater good, for a higher purpose, and that's something that I think has somehow gotten lost.
So picking up on that, I love that she said about competition, because we've got to stop viewing each other as competitors or adversaries. So often we talk in the framework of winners or losers around an issue. And if we're not working on this together, we all lose. We also talk when we talk about health equity issues, sometimes we talk in this context of scarcity instead of reframing it. Instead of reframing it from, you have to continue to cut the pie smaller, grow the pie. Understanding once again that we're all collaborating together. I have so many of you in this room could be here, having this be a part of this panel, having this conversation, because there's so many wonderful things going on in so many organizations. I think of the great things we've learned from El Centro and the Promotoras when we were doing our work around building relationships within communities. I think about the community folks we brought together to recruit the community health workers for Johnson County Department of Health and Environment, and how intentional they were in wanting to hear from different members of our community so that the health workers could be reflective of the communities that they're helping. I think of Julianne with Wyandotte Health and how in your health community needs assessment, you use learning circles in neighborhoods to talk about visioning housing solutions. And we're utilizing that in some work that we're doing. So it's really understanding we can't be proprietary about the work that we're doing. It's not my work. It's not my brand. It's all our work. Because if we're not connecting and collaborating, we all lose something.
Thank you, Julie.
I would challenge us to all think about what community means. It means something very different to everyone. And let's face it, Johnson County isn't that old. Most of us came here from somewhere else. Most of us were not born here. I grew up in a town with fewer than 1,500 people. My kids went to high school at a Blue Valley High School that had more people in it than my hometown. We have to start thinking differently about what community means. My hometown meant something to me, and I understood that from I knew where the touch points were in my community. We have to understand what community means to other people. Maybe it is their school, it's kind of their hub. Maybe it's their faith community. Maybe it is an interest group, a book club, an online moms group that is supporting one another as they're going through their pregnancies. We really have to think differently about what community means, because thinking about community as Johnson County doesn't necessarily resonate with a lot of people. There are many communities within this community. The other thing I would say is, it makes me sad when I meet people in Johnson County who don't engage in their community. They don't get involved in local politics. They don't understand even who's representing them on their own school board or council or their county commission. Civic engagement is something that is actually a social determinant of health, and voter engagement is a social determinant of health. And that's something that we can all work on together, so that we get out and we vote and we get people in office who are representing the best interests of everyone in this community. And it doesn't take a really high profile controversial topic to get us out to the ballot box. And then last, I think from my work on Forward OP and a couple of other projects I've been involved that are more, large scale visioning processes, I always try to think, I listen to my kids and what do I want this community to look like so that my kids who've gone away to college in their communities will come back here and want to raise their families? And what does that community look like for them? And are we doing enough in Johnson County to compete with what is happening in other communities around health and equity and well-being?
Dr. Khan.
So building a community in Johnson County, that's a very complex topic, I think. And if we start thinking about really making it that small town that you lived in, it's the daunting task. And I think we should just think about what difference did I make and take one step at a time. I've lived in Johnson County most of the time that I've been in this area since I moved out in New York. But still, you have, especially as a minority, I can tell you hundreds of stories which are so sad. A neighbor who's been living behind our house, not even like on the same street, for 11 years, had the audacity to stop my daughter on the street and harass her. And her excuse was saying, I have never seen you here. I'm like, if you don't know who lives behind your house for 11 years, you have no right to ask, why are you riding a bike on my street, was her excuse. So we have a long ways to go to make Johnson County into a community. When my next door neighbor tells my other neighbor that he would like to take a drone and blow up my Islamic center. And this is 7 years after he moved, and would see my daughters play volleyball every day. Like he wants to kill me and my daughters because we don't look like him. So it's a long ways before we are going to become a community. Although I come from a city born and raised in Karachi, which is larger than New York City, we were a community. We knew who lived next door to us. If we ran out of sugar, we did ask our neighbors to give us sugar. So, we have a long ways to go, but that doesn't disappoint me. I'm going to continue doing it my way, one step at a time, reaching out to people, getting to know people, inviting people to our Islamic center, getting to know the people that attend my Islamic center, because they come from different communities. During COVID, what we learned is just because all the Pakistani Muslims believed in the vaccine didn't mean the Arabs were willing to take it. Didn't mean that people coming from the African descent in our own Islamic center were even caring about COVID. They thought it was a hoax. So within our communities, we have a lot of work to do. And with this project, I'm very excited because with small things like coming and giving the vaccine, which they could have got from CVS or their health department, but building a trust with the Islamic, between our communities, whether it's the refugee community, through the new mom kits, they get something from the health department. Suddenly they hear about the barriers of, they're our friends. They helped us with the vaccine. Now when we know the next pandemic is coming, as a physician, I can guarantee you that, unfortunately. But next time around, I think we will do so much better and save so many more lives because of the trust we can develop with the health department. The value of a health department within a community is so important. And everything is connected, whether it's housing or mental health or whether or not I have a job. People became alcoholics during COVID because they didn't have a job. So, and then they were probably abusing their kids. There were domestic violence going on, mental health issues going on, suicides. All of it is connected in a society. Everything, even if the trash guy's coming for a month, all of us will be fighting amongst ourselves, within our household when the garage starts stinking up. So everything is connected and every member of the community is valuable. And I'm really glad for this collaborative and I'm really excited to be part of it. And I look forward to what it brings to the community.
Thank you. Thank you. We have a few minutes. Any questions? We'll take one or two questions. I don't want to stand between you and lunch, but any questions for our panelists? Well, if you don't, I am going to skip my question. We're right on time, but there's a lot of good things that we have had and we're taking notes. I heard about the importance of going to the community and not necessarily bringing them to us. I heard that sometimes we are convening, other times we are at the table. I heard about the need to build trusting relationship, not wait for a pandemic before we do that. I heard over and over again that partnerships, collaboration, not working in silos. It's our job, it's not my job. Not competing, changing our mindset, or trying to create similar environments where everyone, all can be healthy as possible. That's what we're all trying to do. Thank you, panelists, for sharing your expertise and insight. I'm sure that they have enjoyed it as much as I've enjoyed it. Thank you for taking time to be here. One more applause for the panel. And Eldona would talk about food.
One more round of applause for our wonderful panel and our facilitator. Okay, I stand between you and lunch, so I think you want me to get on with this, right? First of all, one thing I did forget in all my thank yous this morning, which I totally apologize, our sponsors. We couldn't do it without them either. So we have Health Forward Foundation and KUMPH Population Health Program, and of course, JCCC. So please help me to thank them as well. Okay, so here's the deal with lunch.